Thanks, Alison, and welcome everybody to the QI Community webinar, these lightning lunches, which are proving to be pretty popular format. I certainly find it easy to do, to devote half an hour in the lunchtime to learning something. And we're really grateful to Chris for coming back and finishing off chronic kidney disease. Chris, interestingly, in the last month, I've been looking at some of the data that we collect here at the Fairfield GP unit. We actually extract data from 10 practices, and we've been analysing it in the light of. We also we link it with hospital data and the diabetes unit data. And interestingly, one of the strongest predictor for diabetes patients of admission to hospital is chronic kidney disease. Increases the odds of being admitted 4.5 times. So it really is a silent, in a sense, but very important thing, issues for us to be dealing with in primary care. So a lot of from someone.
Andrew, there's something in someone's mic that might need muting, a lot of background noise.
Yeah. Okay. All right, but over to you, Chris, to take us through a bit more about chronic kidney disease and how we address that in general.
And look, what I might do starting off with, because again, we're talking about high-value things that practices that can actually do to make a difference with kidney health in general practice. I want to pick up on something you just mentioned about the risk of people with diabetes being admitted for 4.5 times. Hello? Hello?
Yeah, well, I'm here. I think someone's is unmuted and has some background noise. So, guys, if you do have background noise, just make sure that you're muted, please. Thanks. Go ahead, Chris.
Okay, so yeah, the really important part, it's a lot of research, when people do their diabetes cycle of care, one of the things that gets, you're supposed to do it every 12 months at least, and that's to do the ACR or microalbumin. And when we look at results in practices, that's often the part that people don't do, as well as some of the other items on the cycle of care. And so it's a really important part that you've actually brought up, that admission risk is much higher in those people with kidney disease. And so if you're actually failing to pick it up early, failing to halt the progression, we really need to be thinking about the job we're doing in our practices. So it gets us to sort of start thinking, let's go back to where we were back in 2 months ago with our first session, Andrew, and saying, let's review the definition of chronic kidney disease.
Thanks.
And the outcomes today we're trying to actually focus on is everyone understanding the definition, what we can use, how we can use improvement principles to improve outcomes for chronic kidney disease in general practice. We're going to talk about building the register, because unless you know your herd in your practice, you can't really keep track of what's happening, because as we all know, unless you measure it, we can't actually improve. I want to really just refresh ourselves on what the treatment options are to delay progression of kidney disease, and talk a little bit about systems to identify people who are at the highest risk in our practices. So next, we'll go to the chronic kidney disease definition. So some of you, I'm sure, were on the first webinar, and just for a little refresher, because the more we remember what this is all about, chronic kidney disease, its definition is if that eGFR is less than 60 mils per minute, and if that's a continuous thing for more than 3 months, and you don't have to have evidence of kidney damage to actually have chronic kidney disease. As I was saying to a patient this morning, he said, I feel well, I don't think my kidneys are a problem. Look, your glomerular filtration rate is 49 mils per minute. It says things aren't that good. You might feel well, but unfortunately things have changed. So we really have to work hard to convince our patients that it's an issue. We find sometimes we've got to convince our doctors that it's an issue, because many of them think that, well, what's it really mean? What can you do? I think today's webinar is all about remembering it's a progressive disease. Identify early. It's treatable with bringing blood pressure down, improving glycemic control, and you can actually make a difference to this person. Alison, we'll go to the next slide, thanks. And just a reminder, so we're looking at numbers. 1 in 10 Australians has chronic kidney disease, but only 1 in 10 people actually know they've got it. And the coding in general practice is a significant issue here, because a lot of practices haven't been coding or unaware of the significance of chronic kidney disease. So if one thing you take away from today, everyone, remember it's common, it's harmful, it's really progressive, just like a lot of other chronic conditions, but it's treatable. So let's go to the next slide. So how do we know there's some improvement happening? It all gets back to measuring our data. And, if the problem we're trying to solve today is improving the detection of chronic kidney disease in primary care and having a systematic approach to treatment, then we need to know about our data. And it starts with our register. So I wondered, Andrew, with your Fairfield general practice, whether you've been looking at registers of people with chronic kidney disease.
No, I've got to tell you, Chris, it's something that we've been working on our diabetes, we're working on our chronic heart disease, but we have not been running the CKD stuff.
Okay.
Get on to.
Well, the fact
convinced by our research that we need to do it.
Well, let's have a look at what we're talking about. Getting that register at risk of people with chronic kidney disease. We also need to know if there's improvement. Are we actually doing kidney health checks? So we'll talk a little bit about what a kidney health check looks like as well. Next slide, thanks, Alison. So what I actually would ask everyone out there to have a think about, if we're going to really look at improvement and improvement principles, quantify how many people with chronic kidney disease are actually in your practice. And you need to actually know how many people are actually at risk of it. So there's two different populations. One, the group that already got it, and the one that may get it. And basically, just to remind you all, 30% of Australians of all ages are at risk of developing chronic kidney disease. And there are 8 factors for development, which we'll actually go into in a moment. But that's huge. When we think about diabetes is a big issue, but when you go 30% of people at risk of chronic kidney disease, this is a nationwide issue. We should all be doing a bit more. So the improvement imperative is actually there today. And if you're looking at how we find people, many of you have been using your extraction tools with Canning or with PenCat or the one with MD that's coming up. That'll help you find them. But you really need to also think, if my extraction tool is looking for the people, how many do you think I should have? And so one of the really key parts is actually benchmarking. And one of the little things I've started doing is people 75 and over who are big numbers of people there who've got chronic kidney disease, often undetected. So roughly you should have about 30% of that group having chronic kidney disease. And so if we actually benchmark it, that gives you a bit of an idea about what your numbers might look like. And I'll just show you a couple of little stats which help you think about this in a different term. So Alison, we'll go to the next slide. And so really this is a group of practices I've been working with, the over 75 population, and looking at their percentage of their practice at 75 or over. And that 30% of this group should be coded for chronic kidney disease, as defined by that eGFR of less than 60 mils per minute. So you can see that the percentages are quite low there. But the next slide, Alison, will actually tell us a bigger story. And this is about the potentially missing a diagnosis. So it starts looking at your practice population, and you can see the gap in how many individual people potentially your practice is not picking up having chronic kidney disease. And when you start looking at those numbers, they're actually pretty big in a number of those practices. You go, hey, we've got a lot of work to do, guys. So if we're going to use improvement principles, we need to actually go, so how are we going to find them? And think about improving care that we provide in our practice. And so unless you start getting an idea about those numbers, sometimes you don't realise how big a job you've got ahead of you. And so when you're thinking about improvement principles, you need to actually empower your team to go out and find the people proactively. And if you've got a lot of people that we've got missing a diagnosis, our team needs to be pretty clued up with what's going on. Let's come back to the next one. So the next slide basically is about delivering effective primary care, which is safe and high quality. That's what we should all be aspiring to. And sometimes when you're trying to motivate your team about why is it important that we do improve chronic kidney disease, this is another way of looking at it. Go, the people 75 and over in our practice are the ones actually taking the most medications. And you look at those practices there, essentially most of them, it average about 50% of this group, age 75 and over, have got 8 or more medications. And 30% of this group have got chronic kidney disease. So it's really significant that chronic kidney disease and medication issues are picked up, because a large number of this group actually has medication misadventures due to often unrecognised conflicts in the guideline care for this group. People often prescribed a whole lot of medications left, right and centre by 4 or 5 of their prescribing specialists who don't actually think about what their other conditions are. And if they've got underlying chronic kidney disease, their level of unwellness is compounded because of medications that are renally cleared and it hasn't been picked up that they've got chronic kidney disease. So chronic kidney disease can often present symptomatically as fatigue, malaise, reduced appetite. A lot of these things are all common, really non-specific in older people, especially those that have frailty. But really, we need to think about this is a group that we can deliver great safe care if we pick up chronic kidney disease and make sure that we're flagging it to our registrars, to our nurses, to the other doctors in our practices so that they can actually prescribe safely and help reduce that medication burden on that group of older people. So that starts getting us thinking about delivering the effective, safe care we must as a practice. The middle column talks about the home medication reviews in these practices. Now, when we're thinking about improvements, we go, we know we're doing lots of medication reviews for these older people, but what this slide doesn't show is that what are those people with chronic kidney disease, are they getting the home medication review? So if we're thinking about improvement, again, which data will make a difference? If we know the chronic kidney disease group, really they're the ones that most need a home medication review if they're on 8 or more medications. That can be an improvement activity by linking in the process of care, which is medication review, with those that most need it. And I think it's really important to understand is that we're often delivering care in our practices because people ring up and make appointments, and we're delivering care. But are we actually delivering the care that is most needed? And we think about improving what we do in general practice. We need to start really thinking about who needs the most care and who's not getting the care required. So that's a really important improvement principle to think about when measuring, linking processes with the diagnoses. Now, Alison, the next slide is about how we build our register. Now, Andrew, you got any questions for me at this stage? Am I going too fast?
I think you might not be going fast enough. We might have trouble to getting through all the slides, but I do have a question for you. I do have a question for you. Say you're one of those practices where you've got 5% of your people over 75 identified with CKD, and you should be up around 30%.
Yep.
What sorts of PDSAs would you be doing to go looking for those people?
Well, so if we go back to that, we've got to build our register. So if our first item for a plan, do, study, act is find the people. Okay, so we can look at a couple of activities under that. So in the slide in front of us is about building our register. So we could use the cleansing cat module for those of us who've got that pen cap on our computers. And this actually gives a very nice a report for practices about those people that have got chronic kidney disease but with no diagnosis. And then you've got a list of all of your people who've got an EGFR less than 60. And so that could be a staff activity to run a PenCat search, export the list into a spreadsheet, and the slide shows you the colours of yellow, orange and red. And so the red group is those that have got the stage of kidney disease that most needs regular review. The yellow is the early stage 3A. So it helps you understand, build your register, and those people that need your kidney health checks. So is that helpful?
Absolutely, yeah. So then you go through and code those people as having CKD, and then they will appear on your register when you do an extraction.
Absolutely, that's right. And you can run this on a regular basis because we know that if we need to actually keep our register up to date, it's not much good just doing this once a year. You really, because we've got people coming back all the time in our practices that are actually having blood tests from either GPs that they're referring, or even hospitals and specialists, and often they're the results that don't come back flagged. The EGFR is one that doesn't usually come back starred or in red. In preparation for this webinar, I was actually having a look at our pathology companies here in Adelaide, and if the creatinine is high, then it'll be flagged. But a lot of older people might have a normal creatinine, but a low GFR, and the GFR doesn't come back flagged. So sometimes people miss the fact that it's well under 60.
Mm.
So yes, from a PDSA cycle. So that's one. The other one is actually looking at your people at risk of CKD. We might go to the next slide, Alison, because that's a really good entree, because those people that have got the risk factors for chronic kidney disease are the ones we need to actually find as well, because many of them will have existing chronic kidney disease, just that we didn't know it. So from a PDSA, it may well be, let's go and look at all our patients with diabetes and see if they've had their kidney health check. That might be one. All those with existing hypertension, they should all be having a kidney health check. So each of these could spin out a PDSA when you actually look at all of the risk factor population. And so it's going to be quite a time-consuming perspective, lots of information, because if these are all very common conditions in our general practices, but it needs a commitment to actually tackle one at a time. As they say with improvement, you can't do it all at once. Let's break it down into monthly activities, delegate the tasks to members of the team, and we'll get the job done over a long period of time.
Now, Chris, I think this is probably an apt time to mention, we were discussing in preparation for this webinar what would be a good improvement aim for practices. You know, the 3 improvement questions, I'm sure you're all aware of it. You know, the first question is, what are we trying to achieve? That sets your aim. The next one is, how do we know we're making a difference? That sets your measures. Next question is, what changes can we make that we think will make a difference? That tells you what PDSA is to test. That first one, the aim I think for the CKD collaborative was to have 90% of this population at risk to be assessed for chronic kidney disease. So I think the practices then systematically worked through these populations to make sure that they had been assessed so that their chronic kidney disease could be identified. So that might be something that you as a practice in dealing with CKD might choose to adopt as your aim, that in this group of high-risk people at high risk of CKD, you might make sure that 90% of them had actually had an assessment regarding their chronic kidney disease. Does that make sense, Chris?
Absolutely. It actually gets us to our next slide, which actually helps put in making the right thing easy to do, because often we go, oh, kidney health, right, I've got to go and check all this. We think about all the associations from the previous slide and what we're doing in general practice. We're already doing the diabetes cycle of care. We're doing care plans for a heart disease. We're doing health assessments for older people with frailty. We can actually incorporate our kidney health checks into each one of those processes that we're actually delivering as a practice. So rather than starting something completely new, if you incorporate it into something you're already doing regularly, you're likely to be doing a lot more of it without actually trying that hard. And so that's a really good tip for practices to say, well, this could be high value and it actually is easy to do. So, and the other part is including that kidney health assessment in the 75 plus health assessment. But that's not standard in many of the medical director or ZMed type health assessments for older people. But you can make your own template and add that, and straight away you're going to start picking up people that you didn't know had chronic kidney disease.
Mm.
And the other part is, again, because people are being reviewed every 3 to 6 months on their care plan review, the opportunity to keep on sort of reviewing the steps of care that if you've missed chronic kidney disease or there's a kidney health check in the first care plan assessment, you've always got the reviews being done. And I think we look at all the research on value for the consumer for care plans. The value is in the review of the care plan. And the value is in the care plan review for the practices as well. If you go to the next slide, Alison. yeah, it shows really clearly here that diabetes is a very prevalent condition. When it's diagnosed and coded, there's a payment for it, so everyone's very good at coding it. But looking at the understanding of having care plans and care plan reviews, how many of us, and again this is from an improvement perspective, actually measure how many care plans the practice did and how many reviews, the 732s, because we should actually be having a 2-to-1 ratio. And if you're not actually a 2-to-1 ratio, you're not actually delivering great preventative care. So from a process perspective of all chronic conditions, including chronic kidney disease, it's a good little PDSA to do. Just say, let's measure what we're doing from chronic disease care, and are we actually reviewing our care plans? And then installing a kidney health check in every one of those care plan reviews. So time looks as though it's getting away from us, Andrew. So let's go to the next slide, just to remind everyone what a kidney health check looks like, because we're banging on about it, and they're actually really simple. So it's simply all those people that we've identified as at risk need an annual kidney health check, and that's a blood test to check their GFR, the urine test to check their albumin-creatinine ratio, and a blood pressure. So pretty straightforward, and those things that we often get done, either one or two of them, but having all three is the critical part to really help us understand how this person's kidney is going. So happy to get some other questions from Andrew.
No, that sounds good. I'm getting some PDSAs that we can look at. Thank you.
All right. Okay. So if we go to the next slide, Alison. So this is, I think, a little bit of a philosophical thing. So we talked a little bit about this earlier, because now that we've got 200 practices around Australia, next year being involved as they calling it the health home, or others of us call it the medical home model. It's about accountable care. And as if essentially 30% of Australians are at risk of chronic kidney disease, and only 1 in 10 Australians that have existing kidney disease know it, don't you think that if we're going to be accountable for the care of our population in our practice, we actually really need to understand our registers, really need to do a lot of this stuff well. And we need to really think about be proactive in delivering the care to those who most need it. The medical home model is not about a reactive approach. It's being proactive in delivering care to those that are unsure that they even need it. And that's where, smart clinicians that are thinking about improvement in your practices, you can use your data, set up your PDSAs, and do some really good stuff for the healthcare of Australia, especially in this area of kidney health. And our last slide is really about looking at the treatment target. So second to last is about treatment targets. Just as a reminder that getting blood pressure goals, 140 on 90 is what we're currently looking at. But if you've got protein in the urine, 130 on 80. Some of you will be aware that there was a study out called the SPRINT study where blood pressures were 120 on 80 potentially, but Kidney Health Australia is currently keeping the targets the same, because what was really important from the SPRINT study, getting the blood pressure way too low with 3 medications led to lots of problems, lots of adverse events. And so we've got to remember that we're going to do no harm. We've got to improve people's health and care, but don't do it at cost. So the blood pressure targets you see on the screen are remaining there at this point in time. Alison, next slide. And something that will help us all keep on track, we've got this great little new app that was launched a couple of months ago called CKD Go. And it basically is a little app for your phone. You put your information in there about the GFRs or the age, and it actually comes up, and you can see on the screen there is that's a red picture, and it has this colour coding of green being good and go, yellow being, yep, stoplight, watch out, and the red is danger. This person really needs the full works. So it comes up very nicely. It creates a CKD plan for you, and that can even be emailed off. But it's really a point of interaction with your patients, whether you're a nurse or a GP. You've got this great app which helps you straight away, and this is actually more clever than some of the stuff we're seeing in our medical software, because it actually shows you the plan as well. It's all very nicely intuitive as an app. So it's a great little thing. So all of your teams out there might want to actually all download this onto your phones, so that when you're working with patients, it makes it easy to access the information.
I think it's a great idea, Chris, because it's one thing to pick it up, but I must say that I have trouble remembering the different levels of intervention related to the different intensities of CKD. So a really good decision-making aid like that is incredibly helpful.
Mm. Well, I'm with you, Andrew, because although I love working with kidney disease, you need those reminders. I haven't got the book open, but if you've got your app, got your phone, most of us have our phones by our sides straight away, whether you're in the nursing home, whether you're doing a home visit, or whether you're actually seeing the person in your surgery. You can share the information straight away with the patient as well. And so I think that's one of the other improvement principles. Involve our patients with their care. It gets them so much more committed and interactive.
Mm.
So the last slide is really just a summary of what we've talked a bit about today, just reminding people that, chronic kidney disease is progressive. That's why we want to do something about it, and it's treatable. And so there's all the myths about chronic kidney disease. Is it just a label? It's not. This is a major issue for Australia. And the other little part that people forget is that the link between cardiovascular disease and chronic kidney disease is huge. It's a marker of future cardiovascular events. So much like you said before about admissions to your hospital, Andrew, where having chronic kidney disease is a marker of admission, it's a marker for all cardiovascular events. So we can actually really make sure we get blood pressures treated, lipids to target, and do something really positive for this group of people. And just a reminder about what the kidney health checks look like. So any questions online that we need to answer?
Yeah, Chris, I think that's a really practical session, and it's great to have GPs, expert GPs, presenting on a topic, because it's the world that we live in, and it's giving us some really practical approaches to managing our practice systems to care for this issue better. Interestingly, I was at our local hospital clinical counsellor yesterday, and they said right across New South Wales, hospital activity is down, reduced. Interesting. I wonder if it's partly because, I'm pretty confident it is partly because general practice is, and primary care is doing a job of actually dealing with chronic disease. And that's our aim, really, to reduce activity in our local hospital because we're managing people better. I think we've got time for one question. If anyone does have a question, just stick it in the question pane. I'll give you a moment to respond.
Well, while you're looking for the question, I think it's a really positive approach. And look, the approach to chronic health conditions, it's a long-term approach, so no one can expect, an overnight change. So, we've all been beavering away over the last decades, once we've now understanding a lot better about improvement. So many thanks to the Improvement Foundation as well.
Mm. Well, it's interesting, with activity-based funding in the hospital, they're all getting a bit nervous because activity is down, so the budget's going to go down. So that frees up money. That actually frees up money to do other things. Okay, so we've got a question from Marie. What would be a child's recommended blood pressure, age 4? Marie, that is a left field question.
It is, isn't it? But, look, off the top of my head, you're basically looking at something around about sort of 70 to 80 over 40 to 50. But I'd need to actually have a good look at that, because there's actually a little formula for children's blood pressures. It's not quite as easy as age. There's age and weight. Now, I can see that there's also, because the child had large protein in blood. Right, well, we've got a serious issue there. There is some problem with that kidney, which needs urgent attention. If that's not a UTI, then this child has a form of nephritis or nephrotic syndrome, which is what's causing that protein in blood.
Epidemiologically, the most common cause would be a UTI, but that is something where, so that is majorly hypertensive, Mary, for a child. Mm-hmm. So I
Wow, look at that number.
presume that your clinic is responding to that in consultation with specialist paediatric advice.
Yeah. Okay.
And Rachel, good to see you installing that app. I'm excited about that app too. I think that's a real positive step to have that available.
All right, well, go out there and everyone sort of install that as their number one activity for the post-lunch session. And look forward to hearing from you how it all goes.
Well done, Marie, for picking that up in Aboriginal Torres Strait Islander people. It's a major, obviously a major at-risk group. Chris, thank you again for your time and expertise and your second session. Thank you, everybody, for attending. Thank you, Alison, for your expert organisation. Again, a very smoothly run, lightning lunch. Well done, everyone. Back to the trenches, have some lunch, get back in there, and we'll talk with you in a month or so at our next QI webinar. There it is. Date and topic to be confirmed. Feedback forms will come to you. Anything else to add, Alison?
No, that's fine. That's all. Chris and Andrew, thank you very much for a very informative and wonderful webinar again. So, and everyone that attended, thank you for your time, and I wish you all a lovely afternoon. Thank you.